Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
If you're a general dentist, have you ever thought about adding a specialist to your practice for maybe a day or two a week or per month? Here at MGE, we get this question from our clients as they become busier. And the reason the majority of these clients consider this idea isn't related to money. It's centered more on customer service and convenience. They reason that if they're referring tons of this work out, whether it's perio, implants, oral surgery, etc., they think it would be more convenient for their patients if all of this could be done under one roof, meaning theirs. Occasionally, you'll hear a concern expressed about losing patients to the ether when they're referred out and potential financial gain, but the main argument is convenience. And that said, we don't really take a position on this. While most of our clients are GPs, we also have a large number of specialty clients, from oral surgeons to periodontists, orthodontists, pedodontists, and endodontists. And add to that a few clients with practices limited to prosthodontics. So when a GP client's looking to do this, it's a personal decision. When we're asked, we're solely advising from a business perspective. In other words, how is this going to work? And in a similar but not exactly the same vein to adding a specialist, you could include the concept of a general dentist looking to add an associate that does procedures, implants, all on fours, etc., that the owner doctor cannot do. It's one thing if you can do molar endo, but you just don't want to anymore. And a whole other thing when you're bringing in a doctor to provide services that you don't have the training for. So with all of this in mind, there's definitely a right and wrong way to go about it. So what would we look at when a client asks about adding a specialist or an associate that does procedures they don't provide? And what would we recommend based on their situation? Well, that's what we want to talk about in this week's episode. My name is Jeff Blumberg, and I'm your host. And I'm joined this week by Sabri Blumberg, our Deputy Chief Operating Officer. Now, many of you know Sabri. She's been on a number of different episodes. She's in charge of all technical delivery here at MGE. She's worked with thousands of clients, and I'm not saying that to be exaggerative. It is thousands of clients. So I felt it would be best to have her on because she's normally the one fielding these questions and providing advice. And I think we have you hooked up over there, Sabri?
I'm all set.
Okay, good. All right, great. Well, welcome to the show.
Hi,
again. Okay. All right, so we're talking about adding specialists.
Yeah.
How often, so I'll start with the first question here.
Yeah.
So how often are you asked about adding a specialist?
Probably once a quarter, about every 3 months or so.
Okay. And so when you're asked, what's the most frequent, how would be a better way of saying this? What specialist are you asked about adding the most? Does that make sense?
Yeah, totally. The most common one is oral surgery.
Okay. And then what would be number two?
Periodontics.
So oral surgery and periodontics.
Yes.
Okay. And how would this conversation go?
Well, usually they're asking me, as you mentioned in your when you were like kind of introducing the concept of what we're doing this week, you mentioned, okay, it's for convenience. Okay. Right? And I think there's different considerations that clients have about this. First of all, yeah, they want it all done under one roof for the patient. They also have a consideration that sometimes they have a hard time getting that patient back because they run out of insurances or whatever, and they can't get that patient back for the year to complete the treatment that the specialist has done. If it's an implant, for example, or even endodontics, right? And sometimes it's just straight up like they're looking at everything that they feel like they're referring out a lot, and they want to keep some of that income in the practice if they can.
Okay. So then let's say you're having this conversation, you're talking to me, and I come to you and I say, hey, Sabri, I think I want to add an oral surgeon to my practice. What do you think?
Well, the first thing I would ask is why, right? Like, why would you like to like, I'd like to get a feel of what they're trying to accomplish with it. Is it for service or is it for income?
Okay, so let's say it's because I find that I don't place implants, let's say.
Yes.
And I'm referring a lot of those out.
Yeah.
And there's also, and again, I'm not giving you exact numbers.
Yes.
In my mind, I'm referring out a lot of patients for implants.
Yes.
And maybe a good amount of wisdom teeth extractions I'm referring out. So then that's my answer.
Okay. So it's interesting because people's concept of what they're referring out doesn't always match the reality. Okay. Right? And I don't know why this happens, and we were talking about this earlier. It seems that certain procedures kind of come clumped together, right? Like the person will suddenly see a rash of emergencies.
I think they always happen in threes.
I don't know if it's threes, but it's interesting. I don't know why this happens, but they're suddenly getting a bunch of patients who need potential
Who need implants. Okay.
Or they suddenly feel like they're referring out a bunch of third molar extractions, right? So the first thing that we do is we actually get the actual numbers.
So you get real numbers.
We get real numbers.
Because a lot isn't a number.
That's correct.
Yeah.
Or 1 month is not something that you can work with. You have to take a look at, like, for the last 6 months, how much did you actually refer out?
That's interesting you say that, because I was going to ask you what's the sample size. So you look for 6 months.
I look for 6 months.
Okay.
That to me is sustained, and it also gives you an idea of how many days a month you want to schedule for the specialist.
Okay.
Right? So that's where you start. You take a look at, well, how much are you actually referring out versus your idea of what you're referring out.
I see.
Yeah.
Okay. So then let's say I tell you I'm referring out 4 implant patients a week for the last 6 months.
Okay. So that probably would be enough for 2 days of oral surgery.
Okay. Per month.
Per month.
Okay. And so then I'd have to find an oral surgeon and all that jazz.
Exactly.
Okay. And then how much would I pay this oral surgeon? What's the usual?
It depends on the area you're located in.
Okay.
Right? So just like with anything, the scarcer something is, the more you're going to pay for it. Right? So if I'm located in an area where there are a lot of oral surgeons that could potentially be an associate for you part-time, you might pay 35 or 40%.
Okay.
Right? If you're in an area that is where it's difficult to find one, you're going to pay 50%.
Okay. So that's the number you often hear, like 50%. That's the one I've heard a lot.
Correct. And it's interesting because that's the number I always heard as well.
Sure.
But that's not true anymore. In the last 5 years, I found that people are paying their specialists 35 or 40% if there's an area where there are a lot of that specialty available.
Got it.
So, yeah, you don't necessarily have to pay that. And I think it's important that you do your research on that.
Okay. Now, if somebody's seriously considering this, right? Because this is where I think it gets a little interesting. So if I'm going to bring in an oral surgeon for 2 days a month to do implants, so now I've got to, and let's say I'm going to pay this person 50%, 45%. Part of the negotiation process, I imagine, is going to be, am I providing the assistant?
Yeah.
Who's paying for the implants?
That's correct.
And any other materials that are needed.
That's right.
Things along those lines. Or what about if we need a cone beam?
That's right.
I mean, I guess if it's only 8 cases a month, we could farm that out to an imaging place.
Yeah, you even have imaging people that will come to your office and just meet you in your parking lot and do it right there and then.
Okay.
You don't have to go buy a cone beam for just a few cases a month.
So maybe have the day the cone beam truck is there.
Yeah, that's right. I would have it make some money before I start investing.
Right. Well, I guess the thing that's always made me nervous about that when I've heard this is if I'm going to spend $95,000 on and I know you can get them cheaper, but, on a cone beam.
Yeah.
And I'm going to only do 8 cases a month, which I guess in the long run, that'll pay for itself.
Yeah.
Because a lot of offices that have cone beams just do the cone beam for free if they also do the implants.
That's right.
But so this is a procedure. I'm bringing somebody in to do a procedure that if they're not there, isn't happening in my practice.
That's correct.
So now if I'm going to invest in this massive piece of equipment, unless I'm planning on learning how to do implants, that could get a little dicey, couldn't it?
Yeah. And what I would like to see is, can you actually pull this off before I start putting more money into it?
Okay.
Right? If it becomes profitable and it's something that works for the practice, then start making it more convenient, start putting money into it.
Okay.
But you don't start with putting money and setting everything up and making it perfect. Before you figure out, is this actually profitable?
Yeah, like after the first month, the oral surgeon and I don't get along.
Right.
And then, that's a problem.
That is a problem.
Got it.
Right. And now you're stuck with cone beam payments.
But I have a cone beam, so that's cool.
That's awesome.
Okay. So then let's say I'm paying the specialist 50% and we've worked out how we're handling the assistant but now I guess here's another kind of just oddball question, right? Because again, we don't really take a position on this and we have a lot of specialist clients,
That's right?
But let's say, because I know with both our children,
Yes.
they had to have their wisdoms extracted,
Yes.
they were impacted and they were sedated.
Yes.
So, I mean, am I going to want to bring that into my practice too?
It's
like
up to
IV
you.
sedation?
I mean, that's up to you. It depends on the space that you have and your comfort level and what clinically you agree with and don't. Like, what do you want? As you said earlier, so well, we don't take a position on that.
Right.
That's up to the client whether they want to do that or not.
Right.
Right. The only thing I'm going to take a look at is, do you have the space to do it? Is it going to interfere with your day-to-day operation? And is it profitable? That's all I'm looking at.
Yeah, I guess if I were to do something like that, like if I were a GP and I were going to bring in an oral surgeon, mainly, let's say, for third molar extractions, right? and some of these are going to need to be sedated, we'd have to be referring a lot out for me to even consider that.
Correct.
Like 5 or 10 a week or something like this.
Correct.
Something.
Correct. Or you can start simple. Start with just the implants and the extractions you don't want to do that are not where you're not using IV sedation. Have it make some money. Then get a cone beam. Have it make some money. And then maybe invest in like getting it set up so you can do IV sedation.
Got it.
Like you don't have to go all in at once. You can do this gradiently as you learn how this works with your current practice. And as your staff gets used to having this new provider and having to schedule for them and things like that.
And then what about, all right, so let's say we've got this oral surgeon who's coming in and we've got some, all on 4 or 6 cases we're doing too.
That's great.
And I'm restoring all these obviously, right? So for the implants and everything else. But, and I think part of it, and you and I were talking about this, part of the thing that attracts, I'm not saying that this is the primary motivation, but some of these cases are $40,000, $50,000, $60,000.
That's right.
Depending on where you are. It's a big lab fee. But part of the problem with these is, if you don't do it right when you get into compensation and everything else, it's almost sort of like Invisalign or Clear. Actually, I can't say a brand name. Sort of like, no, I'm kidding. We can say brand, like Invisalign, Clear Correct, any of these cases.
Yes.
So it's got a large lab fee associated with
yes.
it. So, but then if I'm already paying, let's say I'm even taking the lab fee off the fee when I'm paying for production. If I'm paying somebody 50% to do this case, right? And I'm doing some of it, they're doing some of it. And then I'm paying, a huge fee for the lab and everything else. At the end of it, the big ticket is like, wow, this is cool. This is a big production add to my practice.
Yeah.
But then when you boil it all down, you look at what's left over, you go, maybe not, because I see that with clear aligners. Someone, maybe they don't do a lot of clear aligners. They're really excited because they're 4,000, 4,500, 5,500 a case.
The numbers look good.
They look good at the front end.
Yeah.
And I think it's because there's like not this instant connection, it's not like you're getting the clear aligner bill at the same time you're starting the case.
Right.
So you see somebody jack up the production with a bunch of clear aligners, which is fine if patients need them and it is a service you should provide.
Sure.
But then they don't associate like, oh gosh, 35% of that money's already gone in lab fee. Yeah.
Yeah. And, this is part of the reason why we recommend that these higher ticket items or these items that have a higher lab fee or an unusual lab fee associated with it, higher than your normal lab fees for the dentistry that you're doing. It's almost like you have to treat them like an adjunctive service, almost like you're building a separate practice within your practice. You keep all that separate financially. Like it should be your gravy. It's not your bread and butter.
I see.
Right? Now, let me just explain that more so that
I
like
think
a little
this is
bit
a good
clearer.
concept, yeah.
Right? So you have a practice where you provide certain services. That practice with the services that you are doing needs to be profitable.
So this is with the normal stuff I do. Hygiene, restorative, the normal stuff I do.
Whatever dentistry you do, it doesn't matter to me, but it needs to be profitable and expanding, right? Now I'm adding a piece, whether that piece is a clear aligner or that piece is bringing on an associate that's a specialist or an associate that does treatment that I don't do. Whatever the case may be, that needs to be built separately from your current practice. It can't become your practice because the overhead's different on it. So you have to keep those numbers separate.
So you're saying essentially, if I were to nutshell it here,
yes,
I have to have a profitable, successful practice doing basic dentistry.
Yes.
And then the stuff I add on top is supposed to add to that. It shouldn't become the practice.
Correct. Because, when we talk about bringing in a specialist, usually what we're thinking is we're bringing in a specialist to provide an additional service. But what I see also happening is I see a practice that is barely making its overhead, regardless of what the numbers are.
Sure.
Right? Because you see practices that are doing these great numbers and they're barely making their overhead, and you see practices that are doing smaller numbers having the same problem. Right? But as a solution to their overhead problems, they're bringing in these high ticket items thinking their numbers are going to be better and therefore their overhead is going to be, they're going to make more profit. And the exact opposite is actually true.
Well, and haven't we seen this? Well, not necessarily from the profitability perspective, but this is something I know that because you were bringing this up 2 years ago.
Yeah.
Possibly even longer.
Yeah.
In that, let's say, because we have clients that do a lot of high end stuff.
Sure.
So, but I noticed that you tend to be real harsh about, look, The high-end stuff's great and do it and it's awesome.
Yeah.
But without it, your practice has to be successful and profitable, whatever. That should just be an add-on. It shouldn't be the nature of your practice.
Correct. And even if the doctor owner doesn't want to do the bread and butter dentistry anymore for whatever reason,
Sure.
that's fine with me. But then he or she needs to replace themselves as the general dentist that does the bread and butter dentistry,
The
meaning
fillings,
you
the
go
endo,
get an associate. And that needs to run and be profitable before the dentist steps out and starts doing these specialty procedures.
Like they're only
in
doing
their
FMRs
practice.
and implants and this and that and whatever.
Sometimes they're only doing sleep apnea, or sometimes they're only doing clear aligners.
Right.
And that's fine with me, right? But you can't throw away the foundation of your practice. Right. And it's also the most safe and secure part of your practice.
Well, and in that same line, because we've seen people get in a little bit of a problem with this, in that because if you've got the volume from if you have a general dental office where you've got a healthy hygiene department and you're doing all the regular procedures that you do, you've got volume. So there's all this volume coming in. So then you're finding patients who need teeth replaced. You've got implant cases there. Or if you've added sleep apnea, here's patients with sleep apnea symptoms, or patients who need clear aligners. The volume is providing that. You're not having to go out separately to market for those cases.
Correct. You're not turning yourself into a specialist.
Right. But you're not having to go out separately and market for implants or separately and market for this. They're in your practice already.
Yes.
So the second you start marketing for those types of cases, which I'm not saying is wrong, but you have to make sure your base is solid before you do that.
That's right.
Because then if you're not marketing, if you're now not getting them, you don't have the volume in your patient base to provide those cases, and now you're having to go out and market for it. That's going to cost you money.
Yes, and we have seen that. We have seen that with clients where they are not doing the higher end cases. They hire a specialist that does these huge cases, these $40,000, $50,000 cases.
But they're not always even dental specialists, or sometimes they're just GPs who trained on that stuff.
Yeah, as long as they're comfortable with it, I'm comfortable, right?
Sure.
I'm not a clinician.
Sure.
But they're not profitable with their general dentistry, and they're not making it. Now they're taking what little profit they have in their practice and doing this heavy marketing for these big cases, which is expensive, right? With work that they can't do, paying this specialist an arm and a leg, which is totally fine, but they're going broke at that point. They're basically building a practice for somebody else.
Who doesn't have their overhead to cover because they're just getting a percentage.
That's exactly right.
Yeah. No, I know
exactly
exactly what you're talking about.
Yeah.
So I don't have a successful basic general practice. So now I'm going to go out and market like crazy for all-on-4 cases. I bring in a GP who's trained to do all-on-4s, let's say, because normally with the oral surgeon, they're not going to do the whole case.
No.
They're not going to restore the case, right?
No.
Whereas the GP is going to do the whole case.
Right.
Or maybe I bring in a GP to do implants, and part of the problem when you add an associate is you got to keep that person busy.
Right.
So I brought him in, and maybe I can do bone grafts, let's say, and I can restore implants. So here's a patient, they need a bone graft. I'm not doing this because, I got that dentist just sitting there.
That's right.
And I could restore the case, but, I got that dentist just sitting there, and I don't want him to not be busy because they're, they're there.
Right.
So now I'm giving away all this treatment.
Yes.
I'm spending most of my marketing on that.
You're selling for the dentist very often.
Yeah.
Right. And, you're basically giving somebody else a great life while you're starving, right? It's not a smart way to do it. So bottom line is your practice has to be healthy and profitable, and you cannot change any of your systems, regardless of whether you're doing it yourself, or hiring an associate to do it. If you're personally going to start doing or specializing in one aspect of dentistry, or hiring a specialist.
Got it. So would you say, if we were to kind of give them like a rule of thumb here, so let's say I'm going to go out and get an oral surgeon for implants and extractions, that I don't feel comfortable doing or can't do. So number one, you're going to have me check the last 6 months of how much of this traffic, or if it's a perio for perio surgery and implants or
That's
something,
right.
How much of this I've referred out, like actually referred out, not thought about referring out, but actually referred out, and it's got to be consistent, and then do the math on that based on what I'd be paying the specialist to see if it would be worthwhile doing it, right? And if it is, then I can bring one in for 1 or 2 days a month or a week or however, based on the volume, right? But then when it comes to marketing for more of that stuff, would you recommend that?
You can, as long as you don't change any of your existing business systems, like the marketing you have for your regular practice, and that's expanding and profitable. And it's almost like you're handling it like two separate practices.
Okay.
And the marketing money that you're spending needs to come out of the profit that you're making from the specialty. You can't have one feed the other. It's almost like buying a second practice and having one practice pay for the second practice. You're going to go broke eventually.
Got it.
Right. And that's the way you have to think with
Interesting. So to play this forward, my GP practice does $200 a month, and we're just doing good stuff, basic stuff. I go, okay, I'm going to bring in an oral surgeon to place implants and do extractions. And I'm referring out about 4 implants a week. So the oral surgeon comes in. I've worked whatever deal I've worked with the oral surgeon. Let's say between lab and everything else, or not lab, but supplies and everything else, it comes to 50%.
Yeah.
So the oral surgeon comes in and does about 20, 30,000 a month. Okay. And it's working out well. Okay, I'm keeping 10 to 15 of that. The oral surgeon's getting the rest, right? Depending on how we did the deal.
Yeah.
And then I go, gee, it'd be cool to get more of these implant cases. You would ideally want me to take it out of the profit I'm making from those cases to market it and not change a penny of what I'm spending for my current office.
Correct. The way that I think of it, it's two separate practices. They happen to be in the same location.
Got it.
But they each have to cash flow.
Got it.
Right? You can't marry them together. Because then you start seeing silly things happening, like one practice paying for the other practice, or sometimes because the numbers are better with in that instance, or it's easier to make your monthly numbers with whatever service you added, the oral surgery in the example we're using. The staff and the doctors start pushing for that to happen in the practice, to make the bonuses for the month or to make the numbers for the month, not thinking with, I've got crazy overhead associated with that.
So with that 40 or 50% you're keeping, you're now paying bonus out of that and everything else.
That's right.
Interesting.
That's right.
So it doesn't work from a numbers perspective.
No, it doesn't.
Okay, so that's oral surgery and perio, which are the two most common.
Yeah.
So I guess with prosthodontists, this is essentially a super trained restorative dentist.
Exactly.
It behaves similar to bringing in a well-trained associate.
Yeah, those three are pretty similar, the way that you would handle them.
Business-wise. I'm not saying the training's the same or anything like that. Just to be clear.
No. From a pure business perspective, those three are handled the same way.
They act the same. Okay, so what about, has a client ever asked you to should I bring in an orthodontist?
Yes.
And what's your take on that?
That really depends, because ortho is interesting. When you're talking about orthodontics and even pediatric dentistry, you are now dealing with a completely different organizational model than general or these other specialties we just talked about. Right? We're talking about speed and volume.
So that's ortho and pedodontics.
That's exactly right. So that's the first problem we have when we're bringing this in. It's like, do you actually have the space to do this?
Right, because you might have an afternoon where the ortho's there bending wires on 4 people at the same time, or 5 or 6, and do you even have the chair space?
That's exactly right. And sometimes they say, yeah, but I don't work on Wednesdays. Right? I understand. But if you don't work on Wednesdays and that space is sitting open, how busy are you? And are you going to be expanding your practice? Because you may want that Wednesday for an associate. Maybe you should be opening up that Wednesday and start with the general, and that fits the model you already have. Right. So ortho and pedodontics are far harder to add, just from an organizational flow standpoint. And the other thing, and the space that we just talked about.
With ortho, wouldn't it be, let's say it's a 3-year case or a 2-year case, and I've just brought this orthodontist in, and after 2 months, we don't like each other.
Yeah, that's the other problem. If you don't do ortho, who's doing those cases? Right? Now either you're stuck with that person, or if that person goes skiing and God forbid breaks their legs, right?
Well, I think they could still work with their legs broken.
Their arms.
Hands.
Right?
Yeah. Hands or arms, that's bad. Yeah.
So anything that has a long-term commitment like that with it, I would not, and you can't do it yourself, I would absolutely never recommend that you bring into your practice.
That makes sense.
Right? Just because you're asking for trouble. With pedodontics, now here's another wrinkle, right? Pedodontics, you're dealing with children.
Yeah.
Right? So now you're mixing, and I have been asked about this because some people have a lot of children that they do.
Like they're a family practice. Because I can't imagine a client coming to you who has like a high-end restorative practice going, I'm bringing in a pedodontist. Like that it's not, look, we have kids. We love kids, right?
Of course.
That isn't the problem. It's just, I don't think it's a good mix for, I've got a bunch of 50 somethings coming in for 3-hour restorative appointments. And now I have a bunch of kids I'm running every half hour in the next chair.
It's a bad idea.
Yeah.
And part of the reason it's a bad idea is because, decent human beings are upset when they hear distressed children.
Sure.
Right? Always.
Sure.
Like you hear a child that's upset, that's instantly
instantly grabs your attention.
Yeah. And it's going to distress you.
Sure.
Right? And because children are sometimes distressed going to a dentist, you are adding that emotional stress that your adult patients are feeling by being at the dentist. You're just compounding that by adding upset children to that. It's a really bad idea.
Yeah.
Right? So you don't want to do this. The only time I have actually signed off on this is where you have a scenario where you have, I'm having a lot of adult dentistry being done, but I have a lot of children as well.
So like a big family practice.
A big family practice. And in that case, I truly separate the days.
Like, so they're done on different days?
They're done on different days. And I know they say, okay, well, that's not convenient because the adults want to go at the same time the children are going. I'm sorry. When you are running a pediatric practice, in order to make that profitable, you have to see a lot of children.
That's true.
Right? And the way that you do your hygiene is totally different. And the way that you make your money is totally different. And the way that you interface with the parents is totally different. Because if a child needs a case, you're not presenting that case to the child, right?
They'll be, we don't know if they'll say yes or no, and they can't make a financial decision.
They're probably going to say no. Right?
Yeah, if it were our daughter, she'd just, whatever's the most expensive thing, please, yes, I'll have that.
You're exactly right,
yeah.
But but the other thing with pediatric dentistry is you want to make sure that that your staff is trained to handle the parents, to keep the children calm, to keep the parents calm.
It's a whole different vibe.
Lots of communication with the parents. It's a totally different thing, right? So. And that interferes with the time that you have to spend with adults to really get them to understand what's going on with them so that they purchase the cases that they need to buy in order to get healthy.
So you've pretty much convinced me if I was a GP, I don't care. I would not be adding a pedodontist.
Well, you can if you want to just separate it out. But again, it's a totally separate practice. And the only time...
unless I had like a pedodontic suite on one side with its own staff... And then, in which case, they may as well just be a separately practicing pedodontist.
Right. Well, so the only time I've really agreed to this is it was a Medicaid office, and I know we don't really do Medicaid offices, but this was an interesting one because this doctor was in an area where there were no Medicaid providers whatsoever, and he had his own private office, and him and a bunch of his dentist friends got together and opened one Medicaid office for the children in that area.
Right, I remember this.
Yeah, you remember this. It was actually a pretty cool thing.
Yeah, it was very cool.
It was very cool. So they handled the children there, but they also had adult patients there. And we separated that out there. And it worked.
That worked.
It worked.
So in your career,
where
you've, again, as I mentioned, talked to a lot of people, how often have you said, you should add a pedodontist?
Once or twice.
Okay, so that's not common.
No. And an ortho, maybe 5 times.
And that's a very small percentage.
Very small percentage.
And then what about, I know you and I were talking about this earlier. I've been asked once in my career about adding an endo.
Yeah, I actually only remember seeing it once or twice in 30 years.
It just seems like it wouldn't be a good fit because it's so unpredictable.
Right. And as you said earlier, there's like an immediacy connected.
Yeah, root canal. Like you can come in next month for your implant. You're not going to come in next month for your root canal.
Right.
Yeah.
Right. Yeah. So unless you're seeing a lot of that, for whatever reason, maybe the area you're in, I don't know.
But even then, but think about it. If I'm going to add an endo, unless for some reason I ended up with all my endo patients showing up on the same day of every week. Because you could say, okay, what if I have 10 endo cases I'm referring out a week?
Yeah.
Well, unless they're all coming on the same day or within the same 2 or 3 days. I guess in certain cases, you got to give a patient an antibiotic and a painkiller to let the inflammation go down. They have to see the endo, all that jazz.
Sure.
But yeah, I agree with you. It'd have to be a lot of patients.
It would have to be,
And we'd just send them to the endodontist.
That's exactly
That's
right.
a simpler way to go.
That's exactly right. You usually don't see that unless you have one of those monster practices.
Right. So that makes sense.
Yeah.
That makes sense. Okay, good. Well, I think I've hit you with most of the questions here. Is there anything you'd add on this? As far as, so I'm a GP looking at a specialist. Thought you covered it pretty well in the sense of I should have a profitable practice first before I'm thinking about it. You want to make sure there's a consistent level of those patients coming in. And then before I'd spend money on marketing that procedure, you want to, A, of course, my general practice has to be successful. And B, you'd want me to be consistent before I do that, I assume.
That's right. You really have to do your homework as a business owner before you do something like that in order to make it profitable or not have it mask that you're losing money in your current business, masking that by the production.
Got it. All right. Well, that makes sense.
Yeah.
That makes sense. Well, Sabri, thank you so much for joining me this week. This
You're
is really
welcome.
cool. Now, if anybody has questions about this after they've listened, do you mind if they email you? I can put your email address on the episode webpage.
No, that's totally fine.
Yeah, she'd already said yes before I asked her that. That would be awkward, I think, otherwise. So we'll put Sabri's email address. If you want to, there's a link to it. You can email Sabri if you have questions, if you're looking at possibly adding a specialist.
Yeah.
Otherwise, I think that's all we have for the folks this week.
That's right.
Guys, have a great week, and we will see you at the next episode.